Now I will talk about the natural history of rotator cuff tears. I just wanted to inform you that Dr. Agenskirchner unfortunately had to leave. But you will hear something about the balloon tomorrow from Dr. Lafosse. He will more or less combine the two talks. So natural history of rotator cuff tears. We know actually from experimental data in the sheep model that a release of a tendon, here the infraspinatus tendon, leads to a quite predictable myotendinous retraction of 6 centimeters. It leads to a predictable muscle atrophy of 20%, and it leads to a predictable fat infiltration of 50%, all after 16 weeks. But do we know what will happen to this 57-year-old patient who shows up in our outpatient clinic? Do we know if and how fast his tendon will retract? Do we know if his muscle will undergo a fat infiltration? And do we know if and when this all will end up in an irreparable situation? Actually, we should know these things to discuss with him the treatment options and to recommend either operative or a conservative treatment. So the question is, do full thickness rotator cuff tears progress, or better, do all full thickness rotator cuff tears progress? And if we look in the literature, we actually find some papers, all published in quite high impact orthopedic journals. And if we sum all the results up of these papers, we found that more or less exactly 50% of the cases will progress in tear size within 45 months. And in this ad hoc regression analysis, we see that there is at least a weak correlation of an increased progression rate over time. So if you wait longer, you will have a higher likelihood that the tear will be bigger. So now we can at least tell this patient that he has a 50% chance that his tear will progress. So it's like flipping a coin, and doesn't really make the treatment decision easier. So maybe we can identify risk factors for tear progression. And some authors provide such risk factor analysis. Yamamoto, for example, he found that the medium-sized tear, full thickness tear, and smoking were associated risk factors for tear progression. And he found a mean progression rate in 4 millimeters in length and 2 millimeters in width per year. Maman, he identified an age over 60 years as a risk factor. And Keener published in his 2015 JSES paper that tears with a disrupted anterior rotator cable are at greater risk for progression compared to those where rotator cable was intact. In his JBJS paper of the same year, he could furthermore show that full thickness tears are at greater risk compared to partial thickness tears, that involvement of the dominant side had a higher likelihood to progress, and that pain was associated with tear progression. Mal, Safran, and Mosmer also found that pain is associated with tear progression. And what are the risk factors for muscle degeneration? Herbert Davis found that larger tears at baseline, tears that enlarge over time, and again, rotator cable disrupted tears were associated with a higher muscle degeneration over time. Mosmeyer, he found increased progression rate to advanced atrophy and fat infiltration in painful shoulders. Dr. Fucentese, he looked at the isolated supraspinatus tears here at the bar grist. He had a progression rate of fat infiltration in only 24% of the cases, and he had more fatty degeneration, or found more fatty degeneration in the larger tears. And Kim, he showed that the tear size was the most important predictor for the infraspinatus degeneration, and the disruption of the rotator cable was the most important predictor for supraspinatus degeneration. So you see, it's mainly tear size, pain, and disruption of the rotator cable, which were identified as negative prognostic factors for muscle degeneration. What about the massive tears? Dr. Zink, he looked at, again, the Biogrist patients with massive tears, which were treated conservatively over a period of 4 years. And he found an increased tear size of 3 square centimeters and an increase of the Guttali stage of the supraspinatus, infraspinatus, and subscap of about 1 degree. And 50% of the primary repairable tears became irreparable. And also Mosmeyer, he followed mainly mid-sized tears, found a progression rate to irreparability of 50%. This within now 9 years. So all of this published data relies so far, however, on qualitative muscle judgment. So we grade the fatty degeneration according to Gutterle. For the atrophy, we can use the Dangen sign, or we can do an error calculation on a predefined MRI cut. But all these grading systems are strongly correlated to and therefore biased by the myotendinous retraction. And we therefore rather judge the retraction and not what's really going on in the muscle itself. So in the meanwhile, there's newer technique available, MRI technique available, which now allows us to really quantitatively analyze what's going on in the muscle itself. So with this Dixon technology, we can now measure the fat fraction in percent in the muscle, and with full muscle segmentation, we can really measure the volume of the muscle. And we have so far analyzed the first 17 patients. We had a conservative treated rotator cuff tear with 2 Dixon MRIs in a period of about 6 months. And you see mean tear size progression was 38 square millimeters, which is about 15% progression. It's quite interesting that the volume of this rather small tears decreased by only 2% in this, so mean 2% in this time period. And we had an increase of the fat fraction of only 1% over this time period. We also looked at tear size and location and correlated this to progression, to atrophy, and to fatty degeneration. And here we found again a higher progression rate in the larger tears, especially those which included the anterior rotator cable. So now the question is, can we stop muscle degeneration with a successful rotator cuff repair? And to make it short, yes, we can stop it. In this study, we showed that with an intact repair, we could stop the atrophy and the fatty infiltration in those patients with an intact repair indicated by the solid lines, compared to those where the repair failed. So what happened to our patient? Back then in 2016, he was more or less pain-free, had a quite good function, and he personally preferred the conservative treatment. However, he was unlucky, came back last year with a strong tear progression and unfortunately severe muscle degeneration. So it actually fulfills more or less the criteria of an irreparable rotator cuff tear. So in summary, the literature shows that 50% of the rotator cuff tears progress within 4 years. Predictors for tear progression are muscle degeneration, for progression and muscle degeneration are pain, and initial tear size, and then disrupted anterior rotator cable. And 50% of the repairable massive, but also mid-sized tears became irreparable after 4 to 9 years respectively. Thank you very much. Questions?
Can you comment about how the new MRI fatty or volumetric measurement of the volume versus the fat, how did it change your practice in terms of treatment?
Not yet. We will analyze this as predicting factors. I think, so we hope that we will have a quite large group of patients where we analyze this as a preoperative factor, and then we will analyze it as postoperative factor, so risk factor for re-tear.
What would you say for your patient who came in 2016, if you have someone exactly the same now in 2019, he has no pain, and he has this kind of tear, what do you tell the patient?
With the primary one?
Yes, like this one, you left him alone, he become
if the anterotator cable is disrupted, if it's a mid-sized tear, his likelihood is higher than 50%, and I think I would rather recommend in an In a young patient, in an active patient, I would rather recommend a surgical treatment.
75 years?
An acute one, we actually had prepared one case where we had a 75-year-old patient, he had a ski fall. We treated him primary consultative. We discussed a lot with him, and then what I started to do in borderline cases, I always do an MRI latest after 6 months. And if I see that there is quite strong progression of tear size, of atrophy, and the patient is not doing very well, then I recommend then the treatment, so surgical treatment. If he's fine, then obviously not. If he has no pain and doing well, then